Welcome, everyone, to our session on genitourinary health in all genders. We are really excited to have this session, although not as well attended as we would have liked, but it's because we have a lot of sessions going on, and the layout of our conference is what it is this year. I'm going to work on that for the future. I'm going to be running on a platform of like having an improved venue for future meetings. So vote for me in the spring when that comes up, so that we can all interact and communicate better and have more of a communal experience. So I'm hoping for that next year. But in the meantime, we're going to do the best we can and really focus on a very important aspect of dermatology, laser surgery, that crosses over into gynecology and urology, and that's lasers and energy-based devices in genitourinary health for male, female, and non-binary persons. I will be starting off with my first talk, which is on vulvovaginal lasers and energy-based devices, talking about optimization of treatment protocols. And just so you know, there are handouts available, and happy to answer questions at the end of each lecture. This is my conflict of interest. I have conducted studies for a number of companies, but I don't own stock in any of these companies. Well, every year I really relish doing a PubMed literature search on lasers and energy-based devices for vagina, vulva, and genitourinary tissues. And each year, the number of results has gone up, and never so high as this year. We're already at 1 million hits, and granted, while this may cross over into other applications other than rejuvenation, it still speaks to how important the heaviness of the weight of the knowledge that has accumulated in this area. This year, we published a consensus paper in Lasers and Surgery in Medicine on optimal protocols and best practices with my gynecology and urology colleagues. We categorized the paper in fractional lasers, radiofrequency devices, and HIFEM devices, and worked on the current status, clearances, and future pathways. What I'm going to go over with you today is the results of that consensus, which are the pre, peri, and post-operative questions, concerns, best practices for each of these categories of treatment. The contraindications to genital lasers and energy-based devices are listed here, and they're pretty much consistent across device category. The most important I want to bring to your attention is to always, at the consultation, question your patient as to whether they have an intrauterine device. This is very, very important. Whether it's a copper, whether it's made of some other non-metallic material, the increase in temperature potentially abutting the cervical area makes that a contraindication, as well as with energy-based devices, the current flow into metal. So that is something that I just want to impress upon you, in addition to another very important prerequisite in making sure that they have a negative pap smear prior to treatment, and that the day of treatment you do a speculum exam yourself. The other contraindications are listed here, but those are the ones that I want to point out with great emphasis on a practical note. And the other is that they really aren't indicated for advanced prolapse, stage 2 or greater. So it is very important to assess for prolapse before you engage in scheduling a patient for treatment. This is from the consensus paper. It shows the current status of FDA approval, and it's important to recognize that these devices, the fractional devices, radiofrequency devices, and HIFEM devices, do have clearances for application in the genitourinary area. What we are seeking, however, just to clarify for any confusion out there, is specific indications of GU conditions. It does not mean that as physicians we are not already cleared to treat these areas. We are for general ablation, vaporization, coagulation, and other similar types of indications. Preoperative management. Have the patient for fractional lasers avoid blood thinners for 7 days. And typically, I will schedule it 1 week after the menstrual period if they are still menstruating. And avoid intercourse the night before the procedure. And actually, for fractional lasers, I do ask them to abstain for 3 days following treatment as well for reepithelialization to be complete. I do a pregnancy test prior to treatment. And if there are any signs of infection, we reschedule. The physical exam. I mandate the performance of a speculum exam the day of treatment prior to treatment. This way you can be assured that there's no active infection, be it vaginosis or be it candidal, which you can see on a speculum exam, as well as any evidence of HSV, for which they would be pre-medicated, and then you consent the patient. The great news about these devices is no anesthesia is necessary. So they're actually very quick to perform once you've done your speculum exam. I should have brought a photo. I have these fantastic specula that are translucent. You can see through them. And they have a light that you can place into the case so you get great visibility into the vault. Best practices for fractional lasers. The device settings are provided by the manufacturer in general, but what I want to emphasize here also, and you'll see that when I go over the outcome data, is that more is not better in laser surgery. We are seeing this time and again, not only for vaginal health, but in cutaneous applications as well. Even though we can go up to 30 watts, the laser fluence for optimal outcomes is often at a 15-watt setting, and spacing of the microbeams 1 millimeter apart. We administer the pulse circumferentially. It really only takes 5 minutes to treat, and we retract about 1 centimeter per round of firing the handpiece, so that the typical vaginal length is about 8 to 10 centimeters. So it is a very quick treatment, and it's 3 treatments at 1-month intervals, and maintenance treatments are done at 6 to 12 months. And this is just to show the pictorial of an example of a fractional handpiece being inserted into the vault, and you can see the markings on it that are centimeter markings. Some of them have an automatic discharge in a 360-degree circumference. Others, you have to turn the handpiece manually and then retract, turn the handpiece manually, fire, and retract. And this is just what it looks like right after treatment. What you see colposcopically are microscopic ablation zones, which are tiny white circular macules. And the recovery following this is 2 to 3 days in terms of reepithelialization. And this is just to show you quickly the histology so you can visualize what you're doing with a fractional device. You're in skin, just like in vagina, skin on top, vagina on the bottom. You're creating microscopic columns of ablation that over the course of 2 to 3 days seal up, and you get granulation tissue. Here we're showing you out to 14 days. And it's that granulation tissue that results in the restoration, the remodeling, and the reinvigoration of the lamina propria as well as the epithelium. In the paper in LSM, which I urge everyone to download and take a look at because it is open access, it shows the ideal parameters that was agreed upon by this consensus group for the different devices and the treatment frequency and settings. It's a very, very helpful referral table. Post-operative management, best practices, I say 3 days, avoiding intercourse during this period. Rarely you can see spotting or discharge. Discomfort should be minimal or absent. So any discomfort or burning could signify infection. I haven't observed it. I've never seen it because I take my precautions, but always communicate to the patient so they're on guard to come in and be seen if any such would occur. And shower as usual, but I don't let them take sitz baths of any kind during that 3-day period. And then I follow them up at 1 month. And we do three treatments a month apart following a 6-month to 12-month booster. Moving to radiofrequency, preoperatively, very similar to fractional pre-op. not just preparation, but also the physical exam testing, and no anesthesia is necessary. Best practices for monopolar RF. This is an example where it is a probe that is inserted into the vaginal vault as well as externally to the vulva. And there is a grounding pad, and there are several versions of it, but they all work similarly. It's painless. They administer using a mobile technique, which many of you may or may not know is something I pioneered 20 years ago for radiofrequency. I had discovered that if we keep the skin surface temperature 42 degrees or below, that obviates the need for anesthesia. It doesn't trigger your CNA afferents of pain, but also prevents burns. So that mobile delivery is what is used typically for vaginal treatments, and the target temperature we set on our devices are between 40 and 45. And then in coupling lubricants, we use aqueous gel. Maintain the temperature for 20 minutes. This is just to show you a couple of versions of this type of probe-based system that is, and the way the treatment is delivered, it's a constant movement of the handpiece. You can either do the entire vault or do quadrants. Get to target temperature, go to the next quadrant, and maintain. And that constant mobility, maintaining continual movement, is maintaining the target temperature of 40 to 45 for that 20-minute period. And it has a timer on the device so you know that you've delivered adequate energies. Patient just feels warmth. It's actually quite comfortable, and frankly, it's like completely non-ablative and non-interventional as compared to fractional, which has a fractionally ablative. This is a completely non-ablative procedure. This is just to show you the three-dimensional volumes of heated tissue at controlled depths, creating gentle, non-fully coagulated, just partially denatured collagen, which serves as the trigger for neocollagenesis, neoelastogenesis, and new hyaluronic acid production. Bipolar RF also exists where there is a probe that is inserted and then an opposing probe that is applied externally. This is another technology. This one is painful, and pain control is required. They also, this is a more aggressive procedure. Oral antibiotics are given preoperatively in this instance, and it's done by sterile procedure. So this is the bipolar method, and the cannula is placed into the access port and moved in a radial craniocaudal motion until the tissues reach target temperature. They look at 60 degrees internally and 37 external. The RF devices and parameters are listed here. That's also in our paper that you can download for yourselves, and it is the consensus of the ideal parameters for each of the RF devices. Postoperatively, no specific post-op care. Any discomfort or burning, they should report, and it's 3 monthly treatments that are typically employed. HIFIM is the last of the devices, and here it is a flat spiral-shaped electrical coil. Seated in a chair, you sit in this chair, and it has an external power supply. Electromagnetic energy is directed upward towards the perineum. It is 2.5 Tesla for 28 minutes, 6 treatments, twice a week frequency are typically administered. And the primary indication here is urinary incontinence due to pelvic floor weakness. And when you hear the outcome talk later in this session, you're gonna learn about what the outcomes have been for all these different types of treatments. And these are the current device settings for HIFIM in the genitourinary tract. And again, it is in the paper, and these are the standard settings agreed upon by our consensus group. And then just to round it out, there are fractional laser settings also for urinary applications, a separate category that are here for your perusal. Here it is a catheter that is placed into the urethra, and it is done by urogynecologists, but here are the settings by consensus for this particular indication for urinary applications. So in conclusions, gynecologic laser surgery was developed as an intervention over a half century ago, but it since has amassed a very large body of clinical data for GU applications, necessitating this consensus on best practices. Lasers and energy-based devices are now considered alternative therapeutic modalities for GU conditions, and this large body of scientific and clinical studies have accumulated for GU syndrome of menopause, lichen sclerosis, urinary incontinence, and vulvovaginal laxity. I would say that there are shortcomings in the literature, which we will cover later, but that we were able to reach a consensus on current best practices to ensure the safety and efficacy of our patient population, so that parameters are not exceeded, so that we stay within safe ranges that have already accumulated evidence of outcomes that are favorable. Nevertheless, we are still seeking greater quantifiable, reproducible measures of vulvovaginal health, reducing specific symptoms for fractional RF and hyphen, and I urge you to all download the current consensus on best practices now published in LSM. Thank you so much.